So I want to offer a very special and warm welcome to everyone. And secondly, I would like to thank the organizers for inviting me to speak. Last weekend, I walked into my living room, and my son, who is 3 years old, had a bottle of Gold Bond's foot powder. And he was sprinkling is not quite the right word. He was dousing our nicest piece of furniture. We actually don't have much nice furniture. We don't have much furniture at all, but we have like that one piece of like Ethan Allen, and that was the one that he was dousing with the Gold Bond foot powder, which is my wife's, by the way. Thinking about how I'm going to clean this up, I asked him. I said, Oggs. So his name is Augustus. I said, Oggs, what are you doing, buddy? And he said, Daddy, I'm dusting the chair. And I realized that his interpretation of the word dusting was different from mine. And I was about to correct him and let him know that dusting was actually removing the dust from the chair. And I stopped and thought about it, and actually his version kind of makes sense as well. And it reminded me that the same word to two different people can mean two completely different things. And the microenvironment is like that, actually, where many people use this word, and this is a huge field, and kind of difficult to go over everything in 15 minutes. But I asked my wife, who the one who uses the Gold Bond's foot powder. I asked her if she's a clinician, she's a hematologist as well, and to an audience of clinicians, what would she want me to go over? And so she definitely wanted. She definitely suggested that that I let's see. I need to use the mouse here, I guess. And she suggested that I go over the definition first of what we're talking about with the microenvironment. So, this encompasses many things, and I have probably missed some things on this list. But the microenvironment is the home of leukemia cells, and it's the home where leukemia cells, and especially the leukemia stem cell, resides. And so this can encompass normal cells like the endothelium, immune or inflammatory cells, support cells like mesenchymal stromal cells, even neurons are in the bone marrow. You can also have abnormal cells, and these abnormal cells are sometimes the leukemia cells, or as we'll get into, the leukemia can damage the bone marrow, and these damaged cells are also present. And so the microenvironment also includes stromal components like collagen and extracellular matrix. There's a milieu of signaling molecules like cytokines, for instance. You have metabolic mediators and byproducts. There's a pH component to the microenvironment. There's an oxygen requirement, which is why I actually like this picture, because it's kind of like O from one side to the other. You can see the amount of oxygen that's present in different kind of parts of the microenvironment. There's also the genome and the epigenome, and this is, we always talk about the mutations that are present in leukemia cells, but there are also there's a particular background or backdrop in which the leukemia lives, and the genome and epigenome probably affects that and affects the leukemia. And then there's the surfaceome as well, and the surfaceome is what's external to the leukemia cell, so what's on the surface of the leukemia cells and what is on the surface of the surrounding cells, and how do those things interact. And then lastly, exosomes, which I'm not going to talk about, but these are sort of communicating particles between leukemia and between the microenvironment and the leukemia that can pass proteins, might pass signaling, might even pass genetic information. And so all of this is present with leukemia, and the leukemia has all of these things surrounding it. and yet we don't pay attention to it very much. And so I'm going to also talk about kind of three things. Why is the microenvironment important in MDS? How does the microenvironment influence MDS, and vice versa? How might MDS influence the microenvironment? And how can baseline genetics, what I kind of mentioned when I mentioned genomics, affect MDS? And I'll just end with that. So things changed, I think, when this paper came out several years ago now, where extrinsic factors that by altering bone marrow progenitors, that this dysfunction could actually induce myelodysplasia in normal hematopoietic cells. So in other words, the intrinsic hematopoietic stem cell, the intrinsic environment, was fine. And it was only the external factors that induced the myelodysplasia. The co-first authors on this paper, Mark, I know, and the second first author, you may recognize his name, is the author of the Emperor of All Maladies, the best-selling book. And so, what they showed is that they could actually reverse this process if they corrected the bone marrow. And so, this was a paper that a lot of people paid attention to and really, made us realize if 99.9% of our drugs are targeted towards, the leukemia cell, perhaps some of our drugs and some of our effort and focus should be on the microenvironment as well. And so people like myself who are very interested in, stem cells and stem cell biology, this definitely caused my ears to perk up. So, let's see. Okay. How do I go back on this? Is there a way? No way. Okay. That was it. So I've kind of mentioned now that the microenvironment can influence leukemia, but the way that a lot of people look at this, just like you can look at dusting in two different ways, is that the leukemia can also influence the microenvironment. And why is this important is that the leukemia can instruct the microenvironment so that it now supports leukemia better than it would if the leukemia hadn't instructed it to do so. And so two recent papers from folks in the group that I work in, Rodrigo Giacomo and Lokesh Batula, have investigated this in a TP53 model where there are some similarities in TP53 mutated and TP53 unmutated, as well as several differences in the microenvironment, in the cells that surround the leukemia, depending on the sort of genotype or the TP53 status of the leukemia itself. And Lokesh, who is interested in the osteoblastic niche, and has shown that osteogenic differentiation is induced by AML, and that this actually, what's suggested by this and from this paper and his experiments, that this may actually support AML growth and support AML proliferation. In other words, the AML is instructing the microenvironment to help support it. And so I think that this figure nicely demonstrates where we're at with regard to our understanding of the microenvironment. And just to highlight a few points, the early stage of leukemogenesis likely involves both or one or the other of either a kind of niche-induced abnormality, so in other words, the microenvironment influencing leukemia cells, and or some intrinsic problem with the hematopoietic stem cell. And that as you move to an intermediate stage, you begin to have what I just mentioned, that the leukemia is now instructing the microenvironment on what to do. Still, maybe not clinically apparent disease, or maybe just starting to be clinically apparent, and that proliferation and sort of taking over the bone marrow, what I like to think of as kind of a scorched earth. The leukemia has a kind of scorched earth policy with the bone marrow, that this now becomes very clinically relevant as MDS or AML with myelodysplastic changes. And in addition to this, now folks are looking at CHIP, or clonal hematopoiesis of indeterminate potential. as well as aging and inflammatory markers and inflammatory mediators that occur with natural aging, and that these things all contribute to that kind of microenvironmental influence, and that you actually need both things, a kind of like the Knudsen two-hit model, that you need both a microenvironmental change as well as an intrinsic hematopoietic stem cell change in order to induce leukemia. And so why is this relevant, and where are we going with this? Likely the targeting of the bone marrow microenvironment will become important. And we really don't have too many therapies. We've tested some therapies and are testing some therapies that specifically target or rely on the bone marrow microenvironment. This is a recent study where this mouse model of MDS, which is the NHD13 mouse model, these mice develop a myelodysplasia and eventually develop an acute myeloid leukemia-like disease. That if you take the cells, the intrinsic hematopoietic cells from one of these mice and transplant them into a normal mouse, that you actually don't get the same disease severity. In other words, that if you correct the microenvironment, that you actually can reverse the effects of the myelodysplasia, even in the cells that have the NHD13 abnormality. And so, when you think about all of the therapies that we have and therapies that we're looking at, I'm not going to get into immunotherapy, that's the next talk, but certainly there's a lot of therapies and a lot of ways of looking at this, and a lot of ways of a lot of areas that we can target in terms of interrupting the interaction between the microenvironment and leukemia. Probably the most well-known therapy would be plerixafor, which has been tested to try and mobilize leukemia stem cells from the microenvironment, from the protection of the niche, in order to better treat leukemia. And those studies have not been so successful. However, there are many new CXCR4 inhibitors, many of which bind CXCR4 and don't let go, that may well be successful, so we'll see. So I'm going to end just talking about genetic variants. So we spend a lot of time testing the intrinsic mutation status of AML and MDS. One of the things that we noticed, and I did this work with Dr. Verstovchek, who's chairing this conference. One of the things we noticed is that we frequently will see variants, and usually we don't know what to make of those or how to interpret those. We looked at all of the variants in JAK2 in our MPN and AML patients. What we found is that patients who transformed from MPN to AML had a much higher frequency, a significantly higher frequency of JAK2 variants. When we looked at these a little more closely, what we found is that these variants occur in all functional domains. These variants frequently occur with V617F, what I'm about to show you is that many of them have a variant allelic frequency that's around 0.5, so in other words, one allelic copy. This is suggestive of a germline variant, although not a guarantee for sure, but suggestive of germline variant. And in fact, many of the variants that we found have been described in the SNP database. When we tested these mutations or variants using 3 different platforms, many of them were predicted to be functionally relevant. Many of them, as it turns out, when we looked, had already been described in case reports as being responsible for or contributory, or even tested in the lab in a couple of cases as activating mutations of JAK. And one of the things that we noticed is that certain of the variants in certain regions where the variants occurred were actually associated with chromosomal abnormalities like ploidy and complexity, as well as high-risk cytogenetic features. When we looked at the population frequency of these variants versus what we see in MPN and AML, what we found was that, I go back one slide, sorry. What we found is that they tended to occur at a much higher frequency. The majority of them tended to occur at a much higher frequency, especially 3 hotspots at 393, 1063 and 1108. And so one of the theories is that these are sort of not deeply penetrant mutations, but that these variants may actually contribute to disease pathogenesis. And that brings me to my last slide, which is that when we looked at the variant status of patients who had V617F, so they had a V617F mutation as well as one of these variants, they tended to transform to AML. The cumulative incidence of transformation was significantly greater in this population of patients. And so what this suggests is that the genetic backdrop, or a sort of person's genetics, we've always theorized that this is contributory to a person's leukemia, and that this is actually more important than we might think. And so we're definitely looking at this in MDS, since MDS is and AML with myelodysplasia are diseases that in particular have a huge microenvironmental influence, that the baseline genetics of a patient's microenvironment may actually influence the disease process. And with that, I will take questions.